Okay, so welcome everybody to the Competency Committee workshop today. There is some terrific speakers lined up. Thank you to Julia and Sarah and Wendy and to Allison for putting all of the organization into having this up. We make improvements and tweaks every time that it's offered because I can share that there are always things that are kind of evolving and changing as CBD implementation goes forward. And there's a lot of eyes on competency committees currently. And in terms of the process, the structure, and we're paying attention to those things as implementation moves forward, both at a CBD lead college level as feedback comes up from the schools. And certainly we're listening and paying attention across our own programs in terms of how things are working. What are some of the challenges? How can we help? And so that's what I do listen for during these calls is what experience are the PAs having that are well into CBD and how might we better assess? And we're making some of those changes in MedSys currently to make it easier for program administrators, program coordinators. I know you have various titles. To be able to prepare for competency committees, manage the data in MedSys and the trainee profiles, and do what you do in your role. I always acknowledge how critical the program administrator role is in moving all elements of CBD forward. We've as an update, have and continue to ensure that there's PA voice at each table, all of our committees, and really giving great opportunity through these workshops to support training and orientation. We have another training and orientation session tomorrow, and we're always enhancing the kinds of information that PAs need depending on where the program is that they're working with. So are you brand new to CBD, or you've just crossed into another program and have some CBD experience? And your learning is broad, or are you bringing things forward having been in CBD for a while and saying, you know, this just seems to be problematic. Is there another way to do this, or how are other programs doing it? So that's a benefit of these workshops, and I do encourage it to be really interactive. Use the chat function to post comments or questions. It's all about sharing and helping each other work most efficiently and manage everything well. So any updates from CBME? That's what I've kind of been asked to do today. And I would say with respect to competency committees, we have launched a CBME program evaluation and QI committee. And one of our very focused evaluations will be on competency committees, looking at process, structure, membership, some of the things that are interesting, mitigating bias, what is the kind of data that competency committees are reviewing and using to both review a trainee or to make decisions on progression. And so that's what I listen for in terms of what your experience is. My attendance at competency committees as an observer, and what I'm hearing from PDs and CC chairs and that in the mix, is there's some variability there. And our retreat recently, if you're able to attend, illuminated some of the areas that we do have variability. And in terms of those specifics would be the EPAs that are informing the data, really the breadth of the data and the depth of the data and the accuracy of the data that they're using. So which EPAs and milestones, and how complete is the milestone data? Are some programs assessing all high yield bolded milestones and are using that? What's the quality of the narrative that's rounding it out? Is everybody using CBD forms and an ITER and other WBAs that roll up into the learner summary? We do have a new competency committee dashboard that has been designed with input from PDs and PAs that will launch. It's ready now, and we will launch it as programs go through the training. And so Chantel Campbell we'll start that competency committee dashboard training in November. That Allison has that information. And as those programs attend and get trained, then it will open up to them. And that's really exciting because the work around that was to make it more efficient, make it easier for you. And certainly in terms of the quality functioning of a competency committee, having all of the relevant data at their fingertips to make good informed decisions. That's really what it's about. I like that I followed the conversations in terms of our presenters looking at how do we really manage those residents that are requiring remediation or not progressing as expected. If you attended the retreat, and we'll send out those links very shortly, we did try to uncover and illuminate some of that decision making, and it was interesting to see that there is some variability in those decisions. Having reviewed a trainee that we purposefully wrote as case examples, that some were under the impression they were progressing as expected, some not progressing as expected. And then a more challenging case really was illuminating that some thought it was not progressing as expected, and the other half thought they were failing to progress. So what kind of tips that in those scales, and what's underlying that in terms of the data that they're referring to and being informed by, and also the parameters and the guidelines that determine remediation and when an EEP should be instituted and when a remediation plan should be instituted. And some of that will come forward today, and it can be an ongoing discussion. And if you have questions, we have our PA leads here. We have Sarah and Julia as our PA chairs that can help to find the right answers and facilitate that. And Allison can certainly send out learnings and information that come from today's session. So welcome, have a great session. Thank you to everyone. And let's start with our first speaker.
So my name is Julia Cimarelli. I'm the PA for emergency medicine, and I'm just going to briefly go over the overview of competence committees and how they function. And then Wendy will then take over and explain how nephrology organizes their competency committee. And you can switch this, yeah, perfect. So this diagram just captures the overall process of when an EPA is obtained and all the assessments are gathered. So that goes directly through MedSys. And then what happens from there is that once your competency committee is ready to meet, what they'll do is they'll get the information, all the assessments from MedSys or from whatever program you're using to capture these. And what they'll do is they'll review all the data for each resident, and they will then decide whether each resident is progressing as expected, ready to be promoted, or is not progressing as expected. So then the competency committee will then vote, and a final decision is made to then go to the RPC. Every competency committee decision is a recommendation because it is a subcommittee under the RPC. So once that recommendations are all done, that'll go to your RPC meeting, and then they will ratify that decision. And what I have found helpful is that I now align all of my competency committee meetings to happen directly before my scheduled RPC meetings, so that it actually helps for all the decision letters to go out to the residents in a timely fashion. And you can switch the slide. Perfect. So the role of competency committee. So as I've already touched on, it's to review and make decisions on a learner's achievement of EPAs and their progression through the stages of training toward the national standards as set by each discipline. So it's a committee, again, that makes decisions on the learner's achievements of EPAs and their progression and their overall performance for that specialty. So for my competency committee as well, we also review their exam scores too. So we essentially do an overview of their progress through the program itself. And then we provide guidance for training and different activities to help resident progression within his or her current stage. And then the committee, again, makes decisions and recommendations, and they use this, or they make those decisions directly through the data that is collected throughout the residence training. I'm speaking very fast, I'm sorry. So just as an overview, meetings, the required minimum is 2 times a year, but it's recommended that it should happen 4 times a year. And I find if you're aligning these with your RPC committee, they'll most likely happen 4 times a year. And again, the amount of meetings may increase based on the number of trainees that are CBD. So then the membership, it reflects the size of your residency program. So there is a minimum of 3 members for smaller programs, and a 50% quorum is required at each meeting. The chair of the meeting, or the competency committee rather, is a clinical teaching faculty and is not supposed to be the program director. The program director can sit on the competency committee, but they're not to chair the committee itself. And in terms of preparation and review prior to the meeting, what I found helpful, so sort of throughout their rotations, just to make it more efficient for myself, I make sure everything is captured, and then I put together little review sheets for each resident, or for other programs, academic coaches do this as well. And that is circulated, I would say about a week to 2 weeks before the scheduled competency committee. So there you give a lot of time for people to actually review the data. And you can go to the next slide. Perfect. So the academic coach can attend, but does not get a vote on that specific resident that they're the academic coach for. So again, the competency committee is a subcommittee of the RPC, which means that all recommendations and decisions are ratified by your RPC committee. There is an option to have resident representatives, an external faculty, and any allied health members on your committee. For emergency medicine, we do have resident representatives. So we put the call out to the residents to make that decision, and they all agreed that they would like the resident representative on our committee. And again, it is made transparent at the beginning that any discussions within a competency committee is completely confidential. And in terms of the decision-making process, it needs to be a unanimous agreement amongst the competency committee. And for larger programs, there is an option to have more than one competency committee. And then I'm going to hand it over to Wendy to go through her program.
Well, thanks very much for the introduction. Allison, if you could just go to the next slide. So my name is Wendy Clark. I'm the program coordinator for adult nephrology training, and I've been in CBD now since July of 2017. So just to give you a little bit of background information, we had entered a soft launch, which is basically a trial run with low stakes. So everybody would have an opportunity to get comfortable with this new aspect of education, which is at first steps seemed very complicated, but just allowed us to kind of go through the steps that we had to see that if it was going to meet the requirements of CBD. So we started off with multiple platforms. We developed our own program through JotForm, which mimicked all of the EPAs and provided us the data that we needed to begin reviewing and making decisions based on that information. After a period of time, we then transitioned to Mainport, which was the Royal Colleges platform for EPAs. We did find that useful. However, there were some challenges, and ultimately we transitioned over to MedSys, which was the program of choice that we would be using as a university. One of the things that we found through this was that we had an opportunity for continuous quality improvement. And I found that for that, it was allowing me the opportunity to attempt to trial out different aspects, and things that worked, we continued with, and things that didn't, it allowed us to streamline and adjust and, as I would call it, a tweak to meet the needs of our program. So in terms of our agenda, I would prepare this about 2 weeks before the meeting, and you'll see here a sample agenda on the screen. So I would note all of the residents being assessed. In this particular cohort, we have a 2-year program. We have 6 individuals in the first year and 4 in the second. So I would reach out to the committee members to ensure that they were able to attend, and of course ensure that we had quorum to hold the meeting. 10 days before the meeting, I would assign the file reviewers to each of the residents on the agenda. And then a week before the meeting, I would give them a hard copy package to review alongside of the documents within MedSys. You'll see at the bottom of this agenda that there's other business. So we would also include things that we would need to review at a competence committee level that wasn't necessarily pertaining to the resident evaluations and EPAs. So for example, we were ratifying an academic coach report that we were developing, and then we would also review attendance. You can also see at the top of my agenda, there's a highlighted note for myself, which was to include the clinical competency clinic select block, which was planning for our respective residents. So what that does is those were electives that were provided for residents who needed extra time to work on their EPAs. So in order for us to decide what rotations they would be assigned to, we would discuss it at this level and then advise the residents what they would do in that block. So that before preparing for the competence committee meeting, we would have certain aspects that we would look at. One of the things that I would do would take the resident checklist, which is like a summary sheet, and I'll show you on that on the next slide. The academic coach report, 360 evaluations, that would be including clerk evaluations, professionalism reports. It would also be IPE, which is our interprofessional educators. This would all be compiled within the resident portfolio for the review. As part of the file package that I would give, there is a confidential information. So at this point, because of the nature of it, we didn't feel it was appropriate at the committee level to have this loaded into MedSys. So I would provide hard copy documentation with this cover sheet to indicate that it is confidential. It's to be reviewed and returned to me so that it can be confidentially stored. And this is a sample of our file review summary sheet. It is interactive in that we can click within each of the text boxes and allow us to be able to identify whether they are in the following groupings. So Alison, if you could just hit the forward button. So you'll see here in this column, it's achieved. So any EPA that is reviewed within MedSys and the file reviewer feels that it has been achieved, they would indicate in that selection box that it has been achieved by a check mark. Similarly, if there were no attempts on an EPA, we would identify it in this particular column. And then in progress, so it would be that there are some attempts, but it wasn't achieved. In progress would be identified in this column. And finally, for those EPAs that were not clearly in progress or clearly achieved, we would have that open for discussion. So those ones were the ones that we would target in the competence committee meeting for review to make a decision. Would it be listed as in progress or achieved? The comment box on the far right, or comment line, I should say, would allow the file reviewer to make a few notes as to what the status was on each of those EPAs. On the second part of the form, there is a specific set of evaluations that we would review and make comment on, which would be the ITERs. And I would give a date range, which would be from the one committee meeting to the next. We would also comment on professionalism, and that would be that hard copy document if we were providing that to them for review. Allied health, research, procedures, and an overall summary. So based on the document review, they would also make comments on this. The block schedule you'll see kind of midway on the document there. We provide that so that if for some reason the EPAs weren't achieved in an expected time frame, it may be partly because the rotation hasn't been had by the resident as yet. So this just allows a snapshot of what the resident will be doing for the full year, and the committee member can make an assessment based on, well, the reason it wasn't achieved was because they haven't had that particular rotation yet. So it just puts a bit of perspective active in the decision-making process. Oh, I'm sorry, Allison, if you can go back. So the final box on the bottom is final status recommendation based on EPAs and final status recommendation based on other factors. So this is where the file reviewer would make a statement regarding whether they have been in progress or if they're in failing to progress. It just allows them to enter that information for us to discuss at the committee. And then, of course, progress to next stage, which would be either yes or no, and then the reviewer's signature. So as on the second page of the prior assessment, you'll see here that there is a date range that I need to provide for the ITERs, and this is how you would do it within MEDSIS. So the key part here is that you select the other assessments tab, and under the start date, you would list, within the start date column, you would select end date. You'll see in the second arrow on the bottom there that it says end date. If you select start date, that won't filter it properly. So it is critical that you choose the end date and you identify the start date of the period and the finish date. So you'll see it's highlighted in green text there. So December 4th to December 7th, for example, would be a week time frame, but in my picture, it would show that it would go through till the 5th of January. So notes about file review. In my experience, what I found was I had provided an instructional guide and it was given to each of the faculty members, but not always was it read or fully understood. So we had faculty development where I went through the process and incorporated some feedback from them so that we could all be approaching the file review in the same manner. And the process was ultimately something that was fairly clear and straightforward. The other assessments tab in MEDSIS, again, that is where all of the documents that would be uploaded for their review. We reviewed with a view of how to name the files and what the expectations were for that particular review. The learner summary report was very useful. That's again a feature within MEDSIS that allowed me to provide reporting on specific tasks within the Competence Committee review, and that was also provided to them in a document for them to see. It also allowed me to stay organized and alleviate some of the stress prior to the meeting. For the 4 quarterly meetings that we would hold, for example, and sometimes more frequently, we would have the ability to put those documents in one consistent spot so that we weren't going through a large volume of information. It was just condensed for the period in question. So one of the questions that always comes up for consideration is how do we maintain the security of file review packages if it's done online? So for our particular solution, what we did was we created a private folder within a shared drive that only the committee members have access to. And I have created all of the documents within that for them to complete, and it is housed in that secure environment. So now we're approaching running the meeting. So I have a template sheet that I use for note taking. When you're in the middle of a meeting, I find sometimes it can get very, very challenging to keep up with the conversations and the notes that need to be taken. So this template really allows me to focus on the specifics that I need to record. So prior to the meeting, I would indicate, if you could just hit the forward button, Allison. Oh, sorry. I thought it would highlight there. Okay, sorry. So the top portion that says date, trainee, primary reviewer, and current stage, I would have that pre-populated. And then based on the quorum, when we sent out the email to confirm their attendance, I would identify the committee members present. Again, these are all check boxes that I can click into to indicate attendance. And then the assessments reviewed. So the packages, when I was putting them together, I would know what evaluations they were going to be reviewing, and I would identify those because each resident would not necessarily have the same evaluations. So this just allowed me again to quickly check and identify what was going to be discussed. The status recommendation by primary reviewer. So this is where I'm starting to take notes. So again, clicking into the various status recommendations, which is progressing as expected, progressing as accelerated, not progressing as expected, failure to progress, or inactive. So based on their discussion on what they decided on the file review sheet, I would then identify it there with just a simple click. And then if the committee was in agreement, I would just select yes or no. And then underneath the summary comments and recommendations by the Competence Committee meeting, I would insert text within that would just identify, next steps, things to focus on, what they have achieved overall. And then the final thing was the transition to discipline or foundations or core or transition to practice, whether or not they've actually completed that stage. If it's yes, then we RPC ratify it, and I identify a date in beside that particular line. So after the meeting, I then take all of the information and I'm going to collate it. So as we mentioned earlier, the Competence Committee then takes the recommendations to the RPC. So what we do with ours is similar to Julia. We have our meeting following our Competence Committee, just so that we can quickly ratify things and get the letters out to the residents. The Competence Committee members in our program are also on our RPC. There is no difference. So for us, ratification is fairly straightforward. It is simply just an agreement that what was discussed at the Competence Committee was approved at the RPC, as we have resident attendance. Our residents do not sit on our Competence Committee. So again, respecting confidentiality, we just make the statement that a number of residents have been promoted to the next step and that or the next phase, and it was ratified at the RPC by an agreement by our members there. Could I just ask a question, or by chat or by conversation feedback from other programs, what they would do in this situation?
I can jump in.
Yeah.
So what we do is our competence committee is made up of, we have a competency committee chair, who's one of our faculty. And then we also have my program director, assistant program director, another faculty member. And we also have an allied health professional that sits on our committee as well as 2 resident representatives. So a senior resident and a junior resident that is elected by the resident group. And what we do is that, again, any decisions that we align our RPCs to happen directly after our competency committee. So it's essentially like a week. So I have a week to put together all of the letters and things like that. And then that gets taken to our RPC to ratify. And then the letters are sent probably directly after my RPC. I try to get them out. So it's in a timely fashion for the residents, because there's a lot of anxiety as to, am I progressing? Am I on track? So to sort of minimize that, we try to get it out as soon as possible.
Thanks, Julia. Oh, I see we have a question here from Laura. Where it is tricky is when the Competence Committee members are not the same. Oh, sorry. Allison, could you read that question? It just disappeared from my screen.
Sure, yeah, Laura's just said, it's tricky when the Competence Committee members are not the same as the RPC, and the RPC doesn't feel comfortable ratifying without seeing the data. They trust the decision from the Competence Committee.
Okay, that's valid, yes. So for myself, for the next steps following the meeting, I obtain the file review packages from the reviewers, and then I provide copies of these to and the checklist to the Competence Committee chair. And the Competence Committee chair will provide the letters to the residents the following week, and he copies me on that, at which point I then use those letters to attach to the minutes to substantiate the minutes notes. So my minute template, which I'll show in a few moments, is very generic and standardized, and then those letters accompany it, again, only going to the Competence Committee members, and it substantiates the minutes of what we had discussed. I do also forward the letters to the academic coach, and then once the minutes are finalized and sent with the resident letters to the members of committee, I then would file it as being distributed, and it's again stored confidentially in a secure environment in a locked cabinet. I also take the meeting documents and file it into the individual resident binders. And again, that's also for review in future by Competence Committee members if they need to access back meeting information. So here's my minutes. You'll see that we have the resident progress review, and it's for the 2 years that we have. And then the selective planning, which I referred to earlier, which is those blocks of time that we permit them to work on EPAs if they are falling behind. And then, of course, the completion rates. Of EPAs, for example, we review the process if there were any challenges within MedSys or within the mobile devices, if there was anything that they needed to, maybe account for. So it was a good opportunity to, do a bit of quality improvement in terms of what the expectations are from a resident perspective and what ours are as a competence committee perspective. We also developed our terms of reference. So again, all of these items were reviewed within the minutes in that context, but don't necessarily get repeated each time. It's more of a formalization of specific documents, and then the resident progress review are the typical ones that go for the future meetings that we held. I do develop about a meeting schedule, and we did review the timing of that, which would be, we initially had it a week apart, but then felt that for the sake of consistency and completing everything in a timely fashion, that we would go to the same day. So our competence committee meets first, and then the RPC meets second, which is when the resident representatives for the RPC join us. And we're able to complete that residency program committee meeting in a fairly quick, streamlined timeline. And here's a sample letter from our competence committee chair. And you can see here that it outlines clearly what the status is, whether it's progressing as expected or not progressing as expected. And as Julia outlined, it can cause a lot of anxiety when you see not progressing as expected. And one of the things that we're careful to outline is that there are sometimes rationale for that not progressing as expected, which could be simply a function of you haven't achieved those EPAs because you've not been on that specific rotation to complete it. But by the next competence committee meeting, you may have had that, and then you will be on track. So it's just a capture in the moment where you are right now. It is not something that is going to be projected in future rotations. It's just based on where you are at this point. The competence committee chair does go along to give further recommendations on specific EPAs if there's something that is needed to be observed to complete it. Just again, to give a little more feedback as to why something hasn't been achieved. And then, of course, an open door policy there that you're requesting that they contact the competence committee chair if there's any questions or concerns about the letter. Because again, we want to reassure the residents that this is not a pass fail, it is a progression through. And when they understand that it is a progression of from the beginning of training to the end of training, that there will be varying statuses throughout the training, but we're here to ensure that they progress through the training program appropriately. And this is the academic coach report I had outlined earlier. So it is sent out twice a year to the academic coaches for their feedback. And because they have exposure to the resident throughout their training, it's really useful for them to just give a non-committee member insight as to how to complete or achieve various aspects that maybe they are struggling with. And it allows them to provide us with feedback so that we can tailor the learning opportunities specific to the resident need. And you'll see here at the top, I would complete the resident information for the academic coach. And then the second portion would be their responsibility to complete, and they would return that to me. Now, this particular form was developed prior to it being available in MedSys, and I am going to be looking at maybe adopting the academic coach report that will be utilized going forward. So within MedSys, this is the dashboard. I'm sure most of you may have already had some exposure to this, where you'll see the various EPAs that they would have to complete. Once the committee meeting is finished and the letters have gone out, I would take the file review checklist, and those that were achieved, I would change the status that lists as, for example, in progress, to mark it as achieved. This will allow the resident to know that the EPA has been completed and that they can focus on other ones. The one thing I do remind them about is the completion rate, the green bars. They only move when certain evaluation levels are achieved, which is a 5. And sometimes they will achieve these based on our committee recommendations if they're assessed at a 4, for example. So I ask them to just be cognizant of, while the bars may adjust according to the statuses, it may not read 100%, but they are to review the status column to note whether or not they need to continue to focus on those particular EPAs. And I only do that, just to reiterate, after formal notice has been provided to the resident. I do nothing until I've received those letters from the Competence Committee chair. So this is a phase timeline map. I found it very useful. Our program is a 2-year program. And as you can see, there are the 4 phases. Because our core of discipline starts at block 11 of the first year and travels through to block 11 of the second year, it was a bit difficult for the file review to identify where they were in the process. So I found this phase map very useful to plot out, based on the 2 years of training, where we expected them to be within each phase. So for example, when a file review was occurring, the transition to discipline phase was only 4 weeks, and there's 2 EPAs associated with it. So we would expect them to complete that within the first 4 weeks of the program. But the foundations phase would be a total of 8 months, and file review could occur 2 or 3 times within that phase. You can see my Competence Committee and RPC meetings. They are listed sequentially back to back. I think this was an older one because we have our RPC in block 9 separated out by 8 weeks from our Competence Committee meeting. They're now held on the same day. So the phase map, while it is still the same, our meetings are together. So I believe that this is the status recommendation. So there's actually 5: progressing as expected, not progressing as expected, progress is accelerated, failure to progress, and inactive. I've never used inactive, but that would be for someone who is, for whatever reason, not within the training program for a period of time. So we can just have them listed as inactive until they resume training. The other 4, again, those statuses can change from meeting to meeting. So it is very important to look for what the triggers are for each of those, as Lisa had mentioned. And I think, Sarah, was this where you were going to be coming in and talking a little bit about the various status recommendations and what they represent?
That's correct. Okay, so progress is accelerated. This is something that actually Wendy's group has used. I haven't yet, so I'm reading off of her slide here and what happens during that time, because we haven't had a resident in that situation yet. So when they're an accelerated learner, it means that they're ahead of the target timelines and for their EPA completion. So they're going to complete their training program on time, but they're not going to finish early. It is just going to have the competency committee, academic coaches, faculty, all kind of like band together and create additional learning objectives to include for this resident to get different exposure based on their interest. So they're still got everything done, but they're getting some extra education along the way. And their electives will be utilized, but they don't necessarily contain their EPA expectations. So their electives will still be used towards their training, but the EPAs will be different for this person because they have already achieved them, so new ones can be created. Next slide. Snoopy looks a little distressed there because he's not progressing as expected. This happens a lot in varying degrees. Residents find it, well, we found difficult to believe that they're not progressing as expected. They've always been successful in whatever they've done, and any inclination of some sort of failure or being not on par with everyone else is troubling. So we try to make the experience as positive as possible, allowing for extra time perhaps after the competency committee has met and get some sort of remediation. So the competency committee will decide at what stage they're at. And for example, in critical care, if we have someone who's not accelerating as expected, then they will allow them a little short, brief, intermittent time to play catch up before the next competency committee meeting. So we'll say, okay, you're kind of there, but just not quite yet. We're going to give you a couple weeks and then we'll review it and then have them move on from there. So if it's in extreme difficulty, enhanced education plans are created for the residents based on what they are lacking. And the competency committee and the remediation subcommittee, if there is one in your program, will make a draft with a resident to outline the plan. It's important that everything is documented thoroughly and reviewed, just so everyone's on the same page and there aren't any, issues with, oh, I thought I was supposed to do this, oh, I thought I was supposed to do that, and they end up falling farther behind. The resident in difficulty, it's important they meet with their academic coach, the faculty members, the PD, competency committee, whoever, just to make sure that they're staying on track throughout the duration of the plan. And all of these reports will go to the competency committee. There's a new competence committee dashboard on MedSys, and the dates are outlined there below. So the PAs are on November 19th and the 26th from 12 to 1, and the PD one are those same dates, but I think it's from 4 to 5. And I noticed in the email from Chantel, it said that PAs were welcome to attend to the PD session as well. So just what the new dashboard is going to have is they're streamlining competency committee processes. It will help facilitate meetings through the website itself. It will house all the centralized relevant committee meeting documentation in one spot. It will help improve transparency of what is reviewed as part of decision-making processes, and will also help alleviate some of the current prep work of emailing files to reviewers, competency committee members, etc. Just to touch on that, I know some programs, the PAs email everything out to the person or to the competency committee, the academic coaches ahead of time. Whatever works for you is fine. Personally, I don't do that. Everything is on MedSys. It's up to the trainee to have it up to date. And it's up to the faculty members and the academic coaches to look up that information themselves. If something is missing, I will help them out, but I do not collate packages for them. Everything they have should be available on MedSys for their review. The Competence Committee Review Dashboard program also allows everyone to have the ability to create various competency committee checklists and templates like Wendy has created for her program. Apply the template forms to checklists for coaches, trainees, and committees to download and complete them and re-upload. So just, again, templates that are easy to use, and track meeting dates and decisions, overall statuses, and customize a checklist of individual trainees based on their specific needs. Again, what Wendy is already doing on her own. Hopefully this will be a part of the MedSys process where it's just a couple clicks and we won't need to recreate the wheel.
If I could just interject, Sarah.
Yep.
With regards to that, I was on the MedSys committee dashboard, and this was one of the things that we had recommended because there was a lot of functionality that could be streamlined. So I'm looking forward to seeing this. This is really positive.
Good, good, thank you. Next slide. So we talked about what works for your program in the past. Julie and I had done a presentation actually at a lunch and learn probably last year, and it's all dependent on the size of your program. The geographical location of your program makes a difference as well, because EPAs and milestones are set up by the Royal College, and if you're in a tiny little rural area who needs 15 burn victims, it might not happen. So you kind of, for the first year or so, go through your EPAs and milestones, and it will be a learning process. And you will need to learn to revamp what works for you. We've found out already this year that, well, last year was our first year. And if we don't have our residents in their first 4 blocks in the ICU, then they're not meeting the required milestones. And then they feel that they're falling behind. So we've had to change our scheduling and make sure that they're not in an elective, but doing a core rotation at the very beginning for at least the first 4 to 6 months. And that helps with achieving milestones and not falling behind, which they sometimes feel that they are. Some programs use academic coaches and rely heavily on them. Others don't. They just use the faculty, which is fine. What else do we have here? External representatives, competency committee coaches and academic coaches. Committees are made up of different types of groups dependent on your program. If you've only got 1 or 2 people in your program, it's hard to have a robust competence committee who doesn't overlap with a faculty member who's also an academic coach. So it's whatever works for you and your program. And it's sometimes a meeting to meeting process. What worked at the first meeting is not going to work at the second meeting because you've come up with new issues or new revelations that just aren't working for you. So don't feel badly that you're not sticking to exactly what Wendy is doing or exactly what Julia has done or what critical care has done. It will be different for absolutely everyone. And it's a process. It may take years for you to create what you think is going to run smoothly. And then it could be resident dependent, pandemic dependent. It all adds up, and you just need to take it one day at a time. Another thing that we've discovered that some of the EPAs are not met in person just because of timelines, the types of issues that they are seeing in the ICU, and we've had to create a more robust simulation program to make sure that our people are getting the training that they need. Next. So final thoughts before you start your competence committee. Just connect with other programs in CBD. Read what the PGME has posted, what the Royal College has posted, attend the workshops. We offer a lot of information, read and reread a lot of literature to help you and create a how-to folder of information. And perhaps even collate a list of tasks and questions that you want to ask your PD or even another PA. Don't feel worried about asking somebody else what they have done. That's what we're all here for. We are all learning at the same time. And it is a work in progress. When you get an email from the Royal College saying it's faculty development for the academic coaches or your competency committee chair, don't feel it's only for them. Sit in on that and learn what they're learning as well. So you're all on the same page when you show up at a meeting. Don't stress about it and don't lose sight of the big picture. Improving residency education is what we're here for. Next. And if there's any discussion regarding any of this for Julia, Wendy, Allison, Lisa, or myself, the floor is open.
Maybe to get us started, we can address, Laura had a good question in the chat. So Laura asked if the programs seek feedback from learners regarding their competence committee process. So things like the letter, the follow-up process for those that are identified as progressing as expected, not progressing as expected, sorry, or failure to progress, academic coach involvement, that kind of thing.
So far, critical care has not, but it does sound like a good idea. It would make sense if perhaps we did a survey halfway through the year, just to see where people are and what they think of the process that we're doing and if it's working for them. That's a good question.
A contribution there is some of the programs have asked the residents if they wanted to participate on the competency committees, and a number of programs have shared that the residents declined and didn't want to be in that position?
That was our experience in nephrology. We had opened it as a potential for having them sit on the competence committee. Some were in agreement, but most felt that that wasn't appropriate. So we opted not to have resident representation for that reason. However, in terms of the statuses, we did want to allow the resident in question receiving the letter, if there was any concern regarding the status, because again, that failure to progress or not progressing as expected sounds very worrisome, but sometimes it's just an aspect of where they are at that particular moment, and sometimes just serves as a reminder. Keep focusing on it. Might be as simple as you need to complete 3 to 4 EPAs per week, not achieve, but just submit them for to be completed by the faculty, because if we don't have the data, we can't say it's been achieved. So maybe a functionality of that. So once they understand it's not a pass fail, it's just a process, it tends to smooth things out.
Can just
And I'm going to jump in. Oh, sorry.
Oh, go ahead.
Okay, so in part of our RPC, we have like our standing resident report, and what our chief residents as well as our junior and senior representatives, they bring actually feedback about everything to that meeting so we can address it. So I think they send out a little survey to the residents to sort of gather their information, and then they present that within our RPC, and then any improvements and things like that is noted within that meeting, if that's helpful to anybody.
So it's Lisa, oh, sorry, Sarah, did you have a response?
No, that's fine.
Oh, okay, you lit up. I just, back to with this, with what Wendy was speaking to as well. And this is a curious point to me, because Sarah even mentioned too the distress that may be felt when they're not progressing as expected. And the broader movement is towards a growth mindset in CBD, and this will, it implies a cultural shift both at the learner and resident level as well as faculty and assessment level. But the movement is, and you may be at various stages of this and starting to see some of this happen the deeper into CBME you get, is that learners get comfortable with that feedback. And that starts at the level of EPA assessment, when we start to see more 1s and 2s and 3s and 4s on that entrustment scale, that we move away from them waiting until they think there are 4 or 5 to trigger an EPA assessment. So the data that we start to see in MedSys and the data that starts to inform decisions is more reflective of assessment happening at a formative assessment happening as intended, so that not progressing as expected, as Wendy was alluding, doesn't need to be fear-provoking. That here we're just recognizing that here you are on your timeline, your learning trajectory as you attempt to achieve competency and these milestones and the EPA, that you may not have experienced a clinical learning opportunity that lends to that. And that might be part of it. And then it informs that, illuminates that, and it goes back into the learning plan and the very thoughtfully into ensuring that they can capture that learning opportunity, and that they become more comfortable with, okay, not progressing as expected. What do I need to learn? And I will leave with one of the really positive things that's coming out now from the residents, provincial feedback as well, is that they are really responding to the increase in narrative feedback and to having a better understanding of what they need to learn, when they need to learn it, and that they're involved in that process. So this all kind of ties into the very, the bigger elements of CBD, and it's great that it's being discussed.
I think I maybe can add into that, Lisa, but where I find the anxiety, if you will, is when we have our new learners that have not had CBD before. So if you have, for example, non-Canadian trained residents in our program, they do go through our standard program. There's no difference between theirs and the Canadian grads. But again, it's a new concept, and having them understand the process. And again, that it's not a pass fail, because I think everybody has that pass fail mentality until they begin to see that it really is meant to show a progression. And the other thing that I should perhaps draw attention to as well is when we review our EPAs, initially the residents felt that if they didn't complete all of the EPAs in one particular phase, that they could not do EPAs in the next phase. And that isn't correct, because again, the clinical exposure might occur early on when they might be in foundations, and it might be a core EPA. They can still do those core EPAs. It's just that they haven't been officially promoted into that phase. If they were trying to complete each phase, we would not be able to successfully have them navigate through the phases in a timely fashion. So once they understood that they don't have to stay within that phase grouping, that they can do other EPAs, and that we expect 3 to 4, it's a EPAs per week. It's a reasonable thing to expect that they can achieve, and it's attainable. So I think having them understand that mindset, especially with coming just into the program and depending on where they're coming from, made a big difference for us.
Thanks, Wendy.
And also too, our program, we noticed also with our incoming residents, there was some anxiety getting EPAs and not knowing. We provide them with sort of a breakdown of what EPAs can be obtained where and on what rotation. But what our residents have done, which is amazing, is that before one of our first year residents goes on an off-service rotation, an email is sent out and says, hey, focus on these EPAs. This is what I obtained while on that service and what was easy for me to obtain. So we noticed like just having that constant communication and sort of like mentorship amongst the resident group has been helpful to solve that issue too.
So I just shared that the Learner Development Committee this year put together a resident orientation and training package, really trying to focus on that transition point when they come in new to CBD. And that, as Allison, that's up on our website, correct? Have we, I think we
It is on the PGME website in the orientation package.
Yeah, so the CBME part of the broader PGME orientation package that they get in July, it's up there. Maybe the CBD part can go up on the CBME website. People just wanted to access that. We can send a link to that. Wendy, the other interesting thing, and I'll leave this with PAs to kind of ponder, I haven't figured it out yet, but there is 2 things that are in play here. Everything is evolving as we implement and start to examine and evaluate how things are affecting what. And one is the competency committee plays very much a role in the formative assessment piece when they're reviewing with the intention that they want to be able to identify learners that are moving off track early and intervene early and ensure that the learning experiences are available to them clinically. The other, though, is the tension is the competency committee is playing also a summative role in making finite decisions around progression and recommendations to an RPC. So they kind of play a dual role, and that's of interest. The other thing that I hope PAs can help monitor and inform the broader strategy too is, as we don't want to delay a learner in moving to the next stage of their learning path, but there is prerequisite learning that needs to happen. So a learner that is in transition and transition to discipline and is doing elements or EPAs in core is interesting, because maybe some of that prerequisite learning actually needs to happen in even foundations or in transition, like to jump stages, paying attention to, do they have that requisite learning? And I say that because there is great analysis right now at the provincial level with the specialty committees examining through the PDs that have been 1 year in place and beyond. Do your EPAs fit where they fit? Are there EPAs that need to be tweaked? And there are some subtle tweaks happening to EPAs in versioning and others that are being eliminated, like deleted or changed significantly, foundationally changed. And we're addressing that through a versioning strategy, and you'll hear more about that coming up. The other is, do milestones fit that EPA, or do some milestones just not fit that EPA? What is happening at the program level as you work through that? And I think your eyes and your experience in the competency committees and working with the residents provides an excellent lens, even an objective one, that you can hear discussions that things don't seem to be lining up. So if you can bring that information forward or pay attention to that, it's useful in terms of the overall implementation strategy. Being able to reduce or refine EPAs or reduce and refine milestones is of interest. We want to be efficient, get the best assessment, the best information about the trainee, and not just a bunch of data. We really want to drill down to how we assess and use that data most efficiently.
I think one thing to remember with the rotation structure, at least within our program, I know perhaps in the surgical programs, there's specific timelines where everyone is doing kind of the same tasks or aligned such that they can work on EPAs sequentially. But with ours, it's very much rotation specific. And while we do have, yes, graded EPAs throughout the program, if they only have 4 weeks or 8 weeks of exposure in the first year, if they don't focus on the EPAs where they're sitting, even though it may be a core, they do have exposure in foundations, but they might want to do both foundations and core, depending on where their rotation falls, because not everyone is doing the same thing at the same time in our program. So we really have to be, cognizant of where they are in the process. And that's why we provide the rotation schedule to allow those decisions to be made. If there were more advanced things, then that, yes, of course, that would occur later on. And those would likely not be attempted or observed until their second year of training, when they get another rotation on that particular service.
Yeah, thank you. And that's extremely reasonable. They don't only get one shot at learning something, right? And things can be so complex that they learn parts of it. You think of a larger task analysis, they might learn parts of it and then come back later in core and learn something more deeply. And that learning builds on it. And that's the way it should work. So thank you for that, Wendy. That was great.
No problem.
Any other questions? Competency committees are fascinating. I love this workshop.
Maybe I could just interject one thing here. I see from Rochelle that she has utilized some of my templates. I'm so glad to hear that. I did make available my templates that I showed in the presentation today. If anyone would like further clarification or discussion around those, I'd be more than happy to discuss individually with you offline. And if you would like those templates, then I'm assuming that these will be uploaded to the site. Is that correct, Allison?
Yeah, exactly.
I do have one question. It's Laura. Just regarding the academic coach involvement around the letters that are sent to the learners. Is there a reason that the academic coach is not looped in when the Competence Committee chair provides the letters to the learner? Did you decide that for a certain reason?
Because our academic coaches are not part of the Competence Committee meeting, we do include them getting the letters after they've been done because they're not part of the discussion. They do have an opportunity to provide a report twice a year for us to allow us to make recommendations based on their input throughout the year with the resident meeting on a regular basis. So we didn't feel at our level that we really needed to have them as part of the letter process, that I would just send it along as once the resident have received it for their review and discussion with the resident for next steps.
This is an interesting point as well. And it's come out through our academic coaching workshops and discussed among academic coaches, but also the PDs on the call. In the model, academic coaches are really about coaching the resident. And if they were to have an assessment hat, then it kind of changes the dynamic of that relationship. And they're trying to keep it as organic as possible. And academic coaches typically don't. They may present they may be the primary reviewer presenter, more the presenter, sorry, not the reviewer, the presenter, because they know the resident so well, but not to really be partaking in any of the review and assessment process. that happens. It gets a little challenging, and you PAs that are in smaller programs and there's more faculty that are wearing more hats and they have to populate a competency committee and an RPC, and there's only a limited number of faculty. I think it gets a little more challenging to keep them removed from the entire process. I don't know if anyone has comment about that. I'm wondering if we can, we have a little bit of time. I'm wondering if people can either enter into chat or just comment open, it's a small group here, what they think the what works the best at their competency committee. What seems to be like really working well, that if it didn't happen, it would just be really difficult to get comprehensive assessment done. Could be related to anything, getting through all the numbers if you have a large number of residents. It could be the types of members, how the competency committee process rolls out, the time, like anything. What works well?
I'll speak up. One thing that works for us is we don't have a detailed template like Wendy, but at least having something in place beforehand with everyone's name and who their coach is, something listed. And then that way, when you're writing down the notes, it's all just right there. And then you just need to fill in the details and copy and paste to a letterhead to make it into a letter. That really, really saves on time, because there's a quick turnaround from the competency committee meeting to get the letters out, to get them reviewed by the committee to make sure they're correct, and then presented at the RPC. So any sort of template you have, whatever works for your program, seems to really, really streamline the actual meeting itself.
Great point, Sarah.
One of the things we have discovered over multiple meetings is that in order to really effectively review each resident, because we would review all files at each meeting, would be to provide the competence committee chair the agenda ahead of time. He actually will review the documentation that has been file reviewed, and then he will make a decision as to how long each resident should be reviewed for. So if the resident is progressing as expected and it looks pretty reasonable, then it's just a minimal, few minutes that is provided for discussion. Where a resident is maybe having, maybe a learner in difficulty status or not progressing as expected, and there might be just a little more question as to status, then a few more minutes would be allocated. And having those timelines presented right at the beginning really facilitated us being able to go through the agenda in a timely manner. We only allow, an hour and 15 minutes for our meeting, and we really try to stay within that time frame. Otherwise, we can quickly go off track and spend far more than we anticipate in discussion.
Oh, Laura, works well. Tracking spreadsheet for large programs to follow up on those that need an EEP. Oh, good point. Academic support or more frequent follow-up reviews. Track status, next steps, and next review date. Excellent. I'm curious as to, again, there's, variability, and some of the things I'm listening for as you present and talk about what happens in your programs is pulling out some of the best practices that are going to help those that are coming behind you, so that they don't have to go through the whole learning cycle you did, but we pull out things that really work well and can save them some grief. So these are great, and we'll capture these and share these broadly, and it'll also help us put things up for PAs up on our website and anything else that we do to share these ideas. I guess one of the things that was curious for me was how programs cycle back to the resident if it's identified that they need to address a few more milestones. If you're actually looking at the high yield milestones that are captured in MedSys and they're in the learner summary, you can actually use the EPA and the milestone graph in MedSys to say, wow, some of these haven't even been assessed. And these are kind of critical. So they might be reassigned to the resident. And as what was just expressed is it might be reassigned into their learning plan or in an enhanced learning plan. But it also can be reassigned in MedSys. So there is a button beside those milestones that you can click in MedSys, and you can add additional learning there there's a whole column for it. And I don't know if that functionality is used, but there's a way to create the alignment with what's being captured in an EEP with what's being entered into MedSys. So some milestones that can be left pending or achieved, but some can be reassigned and it'll populate back into their MedSys dashboard. Julia, I do these for each resident being reviewed. So each resident has their own review card. Excellent. So if you'd like to share these tools, we can upload them onto the site. And if we can find a way to package everything around competence committees for PAs, we'll do that. We make a toolkit. CC guide for residents. Yep.
And that's just more, I guess, program specific, but it's kind of, it outlines if I'm a learner and I'm looking at my letter and it says that I'm not progressing as expected, what the next steps are, and involvement from all parties, and just to really kind of outline the whole workflow.
Excellent. I had shared recently, maybe August, there was a new Royal College resource for called Competency Committees for Residents. There was even a workshop that was captured. I think the link to that webinar, archive webinar, went out to you as well. If you didn't receive it or you're interested, that's up. I think the resource, Allison can confirm that it went up onto the website. And so it really explained in a webinar form, and there was I think a 2-pager or a 1 to 2-pager for residents on competency committees, and then how your program addresses it and prepares, and all of that is a nice, very important guide for them. I agree. That's great to see. So I will encourage you, as things roll out from the program eval committee and we start to more systematically evaluate competency committees, please feel free to chime in or share the surveys or anything, focus groups or any other methods that we use to evaluate around this. We will be definitely involving the program administrators, but please never feel that even what you share based on what experience, limited or otherwise, that you have, it's all valuable, because everything is in motion and you all have your own experience within programs that can be useful and informative to other programs, but also to the broader strategy. So just encourage you to pay attention for that and participate if you can.
For attending, and thank you, Julia, Wendy, and Sarah, for presenting. And like we've said, this was recorded, and we're going to post the recording on the website, as well as all of Wendy's templates. And if anyone else has something that they would like to share, a template or a great resource, we could definitely post that as well to share with other PAs. So thank you so much, everyone. Bye.
Bye, everybody.